This is the next session in our conference, Bridging the Divide Between Hospital and Physician Finance. Thank you all, our sponsors. Without your support, we wouldn't be able to offer these education and networking opportunities. When I plan the budgets with Marty and the executives, we definitely look at that line item, and we certainly do appreciate all you do. And if you're sitting in the audience, enter the raffles, get your poker card, and compete for some fun prizes. So this session's worth 1 CPE credit. If you require CPE, and if you're joining us virtually, note that you'll need to remain logged into this session for the duration to receive credit. Also, for our virtual members, during the presentation, you can ask questions by clicking the chat button at the bottom of your screen. We all know how that works with Zoom. Good to see everyone remote. You're all kind of hiding there, though, so I don't know. It's freaking me out. It's all right, though. But if you're joining us in person, we'll also be taking your questions live at the end of the presentation. So I'd like to introduce our speakers real quick here. We've got Ann Peterson. She's a finance executive with 30-plus years of experience in healthcare and a proven track record of significant financial and operational performance improvement in large multi-specialty academic and community-based group practices. She's currently the Ambulatory Services Financial Officer at Evergreen Health. She's also our president-elect. Jessica, yeah, yes. She comes from the Illinois chapter, where has how many years experience? She served in multiple roles and 6 years with the Illinois chapter, so we're happy to have her here. And Jessica Granger behind me here is a healthcare finance professional with 15 years of experience in public accounting and healthcare finance. She currently serves as Director of Financial Planning and Operations for Evergreen Health in Kirkland, overseeing system-wide operating and capital budgeting, long-term forecasting, cost accounting, and financial analysis that supports sound financial decision-making. So after all that, Ann and Jessica, it's all yours. Take it away.
Is my mic on? Is that, you can hear me? Oh, cool, because I can't even hear myself. So thank you for being here, and I'm so excited to see so many people in person. This is great. I wanted to just have a couple of comments before we start our presentation. Number one, similar to Wando yesterday, we don't pretend to know it all. We think we have some good ideas to share, but even more importantly, we're hoping that you'll share some good ideas from your organization so that we can all come out with a broader set of knowledge. Let's see, this session we want it to be very interactive. We'll be teeing up some questions and asking for responses, and to encourage those responses, there's a very nice full bowl of candy that will be circulating with the person holding the microphone, so the more questions, the more examples to share, the better. We only have about 30 slides in our presentation, so if there's no participation, we'll be finished really quickly. So, all right, so let's get started here. So these are the learning objectives that were contained in the agenda, the schedule. Oh, thank you. And really just what we hope that you'll get from this is really learning a little bit more about how service line strategy can drive financial planning, learning approaches to hospital and professional integrated financial planning. And I think that's really an important piece that we want to cover, is sort of how we have learned to have an integrated approach, so that we're looking at things holistically and making sure that if this is what we plan on the facility side, do we have the docs to staff it, and vice versa? If we have this huge amount of growth, do we have adequate facilities? And then again, sharing industry expertise and best practices related to hospital and physician finance, just very generically. So any ideas, we're happy to have them, and we'll give you candy. Okay. So we're going to give you a little bit of background about Evergreen Health. So I'm new to the market, many of you may know. I moved from Chicago about 18 months ago, drove cross country in the middle of a pandemic, and so I'm still learning the market. I don't have all the years of history. Jessica's from the area, so she knows a whole lot more about the market and the players in the market. But I thought it was important that we give you some context as it relates to Evergreen. Then we'll talk about our service line approach to strategic and financial planning, our integrated annual budgeting process, which seems to go on forever. And then we'll talk a little bit about capital planning and budgeting. I think we've got some innovative things to share. So, and you hop in if you have anything to add. Skip that one. So I might ask for Jessica's help a little bit on this one. So just in terms of Evergreen Health and what we have. So we have 2 hospitals. So we have one in Kirkland, which is sort of the large main campus, but we also have a hospital in Monroe. Both hospitals are hospital districts. Kirkland is a King County hospital district, and Monroe is a Snohomish County hospital district. We also have a medical group, so Evergreen Medical Group, which is, we are all under the same tax ID number in Kirkland, so it's a separate kind of on the org structure, but organization-wide, it's the same entity. We have a very large, I think it's the second largest hospice and home health program in the state. Very, very busy and growing. We have way more demand than we can support with our staffing. So like everybody else, we're crazy busy trying to recruit and fill positions to grow our business. And then we have some strategic partnerships. So we'll talk a little bit more as we get into service lines, but we recognize that we can't be everything to everyone. And so we formed strategic alliances. So Seattle Cancer Care Alliance, one example of a partnership that we have in place. And then we have a great partnership with Overlake on a few of our service lines. Our neurosciences, for example, cardiology. So we're avoiding some of that duplication and creating more of a regionalization approach through that partnership. Anything you'd add? So Evergreen turned 50 years old last Wednesday. We had a very lovely celebration, including cookies in the shape of that 50-year emblem. And so very proud. It's got a great history. So just a couple other stats. Over close to 300,000 outpatient visits. Between our 2 EDs, we have about 60,000 ER visits a year. We are a very large birthing center and in the midst of a baby boom. So we're doing 4,700 plus deliveries a year right now. The last place I came from, a community hospital, we were struggling to get to 700 or 800. So and that place was bigger. So lots of baby, and it speaks to the demographics of the area as well, but that's a major service area for us. We have urgent care locations. We have 7 urgent care locations, and that really feeds the beast, if you will. We do get a lot of downstream from that. Another unique thing about Evergreen, and I'm not sure if any of you have heard, we have a health line, which is something that I've never seen in my career, but it's a service that is levy funded, and it's a nurse triage line that anybody can call with medical questions and get triaged. And then you be provided with recommendations for, should you call 911, go to the hospital, should you see your doctor the next day, that type of thing. And so through that service, we field over 100,000 calls a year. We also provide that service. We serve in that function for Virginia Mason and a couple of EMS services. So we have over 4,700 employees and 1,100 providers on our medical staff. Oh, and over 800 million in net revenue. So this is a picture of our hospital, very beautiful, fairly new tower. And on the top of the slide, we speak to the fact that we were the epicenter of COVID-19, and probably many of you know this already. And this was before my time, so Jessica has, I'm sure, way more color commentary, as many of you probably do in your experience. But on February 29th, Evergreen became the first hospital in the U.S. to test and treat for a wave of COVID patients. And I believe we had the first COVID fatality at Evergreen. So I'm going to go down a little bit further, and then I'm going to have a video teed up just to kind of bring you back to, I think it was from March 6th of 2020, so right in the thick of it. So just some examples of our initial response as the epicenter. We immediately activated the command center, which I'm sure all of you did as well. We were the first, though, to implement drive-through testing, and we did it in the basement, in the parking garage of one of our buildings. And the goal of that was really, we needed to test first responders that were going and picking up these patients from the nursing home where all the cases originated. We also had a very rapid deployment of negative airflow patient rooms and telehealth, as many of you did. I've talked, over the last couple of years, many organizations have rapidly deployed telehealth as another strategy. and develop the reopening strategy in collaboration with the medical staff, really being very thoughtful about how can we bring business back. So Adam, can we tee up the video? And I'll just set the stage. This is a video, an interview with our CEO, Dr. Tomlin, who is a phenomenal leader and has led us through this pandemic in a manner that keeps people very calm, and he really exemplary leadership, I would say.
When patients here at Life Care Center of Kirkland Nursing Facility are overcome with respiratory symptoms, or if they get coronavirus, they're rushed off to Evergreen Health Medical Center, less than 2 miles away. The doctor in charge of it all says his staff is prepared, and they've been training for this scenario.
For our staff, there's a feeling of intensity. So the people are working really hard and meeting the challenges of what we're facing. The staff is calm.
Dr. Jeff Tomlin is CEO of Evergreen Health in Kirkland, where several patients with coronavirus are being treated in an emergency department sealed off from the rest of the hospital. Not even air from that section can flow to other parts of the building. If somebody walks in and they're showing some symptoms, and they need medical attention, what happens right away in that moment?
First thing that we do, and everybody's been trained with this, the first thing we do is get the patient mask and the patient and the person caring for them mask, and then we'll try to get them to the proper care. In this case, it would be our emergency department.
Dr. Tomlin says some Evergreen staff have tested positive for coronavirus, but it's not clear if they caught it in the community or at work. Were the appropriate protections in place for staff who'd be handling those patients?
So the protection would be the same for a bad flu outbreak. So they were all protecting themselves for what would be respiratory precautions. So they were doing that.
What do you think the next few weeks will look like?
I actually think the virus has been here. I think we're going to see more community-acquired cases rather than just from the local facility. I think the hospitals in the area, you're going to see increasingly caring for people with that. And I think the rest of the country is going to see it as well. It just so happens that we were first.
The Washington State Nurses Association pushed back on some of what Evergreen Health said. They say some of their nurses who work at the Kirkland Medical Facility and came into close contact with coronavirus patients are not getting timely answers from their managers about what to do next, or they're getting conflicting responses on whether they should quarantine. In Kirkland, Ted Land, King 5 News.
So that was a week into COVID, and the CDC showed up at Kirkland, and they didn't know what to do either. So it was kind of interesting, 2 years later to kind of play back in, the immediate criticism that was out there about, rather than how can we help, how can we criticize. But so we just want to kind of give that background perspective just to set the stage, because I think that COVID has clearly affected a lot of our financial planning over the last 2 years and kind of as we move forward. So anything to add before we move on to the next section?
The thing that just kind of speaks to me as we listen to that video clip is just, like Ann was saying, how many unknowns there were. And, now you can hear me? How many unknowns there were in those first couple of weeks and months. And of course, we're still learning. But really now being able to reflect back on it a little bit, it sort of triggered this collaboration that only a pandemic can. And people working with other areas that they might not normally work with, even people stepping into totally different roles that they wouldn't have played, in a different scenario. So one of the keys for Evergreen, I would say, and we had a really wonderful, strong emergency preparedness program to begin with, which really helped us in the situation. But being able to have those debriefs and lessons learned throughout the process, because we're constantly having to be innovative and creative in our response to the pandemic.
Great. All right.
So with that, the other thing, we're going to move right into our service line approach to strategic and financial planning. And what's sort of timely about this process was that we were sort of just starting to do a deeper dive into our service line strategic planning at the beginning of 2020. And so once the pandemic hit, it became even more important that we were sort of focusing on this very intentional growth in specific areas because we found ourselves in an unanticipated financial crisis. So the timing was very coincidental. And then before we sort of move on to the next slide, I wanted to just to start with a quote. So far and away, the best prize that life offers is the chance to work hard at work worth doing. And so some of you may recognize this quote from Theodore Roosevelt. But what it kind of reminds me of is that even though, especially in the finance world, we can kind of get sidetracked by the numbers and kind of like forgetting a little bit about the purpose behind it and the connection. To me personally, going through the beginning stages of COVID and going through this pandemic really helped me sort of reconnect the work I was doing, even though it kind of seems like it's behind the scenes sometimes, to the overall, what's going on in the world right now and the purpose and sort of the worth of that work. So, it's not always easy to think of this work as the best prize that life offers, especially on the tough days, but it is a good thing to kind of think about that helps with perspective and grounding. So I would just keep that in mind as we sort of go through this process, because I'm sure that I'm probably not alone in having those tough days thinking, what is the purpose of all of this and how am I contributing to the greater picture? So with that, this first slide here is showing a best practice planning cycle. So this is not exactly the cycle that Evergreen Health follows, but it's pretty close. And as we go through this, we're going to kind of start each section showing this calendar. And I'm curious to know sort of as we move through the presentation how this might relate to or be different than the different planning cycles at your organizations. So first we're going to start talking about the planning cycle. So it's market assessment, strategic planning, and financial planning. This is for a calendar year organization. So it starts even before the year with market assessment in November and December. And then, of course, jumping right into strategic planning in the beginning of the year. And then financial planning, as you can see, lasts a good portion of the year. And the idea is that the market assessment and the strategic planning helps you set targets and goals that will then feed your financial plan and then into the nuts and bolts of the capital allocation and budgeting process further in the year in anticipation for board approval. So there's a lot of words on this next slide, but really, when we're thinking about service line planning specifically, there are a number of things and a number of different areas that are sort of driving this change towards service line planning. Now, some organizations may have been doing this for a very long time, and I think at Evergreen we were doing it to a certain extent, but really decided to, or really kind of made an effort to be more, to have it more of as an initiative at the forefront. In light of financial position and just all of the rest of these drivers. So first it talks about increased competition, creating the need for differentiated services and growth opportunities. So this kind of goes back to what Ann was referencing earlier about we can't be everything to everyone. So where do we want to focus? Where do we want to be best in class in our organization for what services? And making sure that these services are all in alignment with our long-term strategic and financial goals and helping us achieve those long-term goals. Next talks about the significant investment in providers. So obviously, physician recruitment is one of the key elements when we're talking about supporting growth in service lines. And also when we think about integrated physician and hospital finance, it's important to make sure that this provider growth aligns with the facility volume projections, and also that when we're looking out 5-10 years and looking at our recruitment plan, that recruitment plan is timed accordingly with when we expect growth, when we might need to invest in capital, and it's all kind of interrelated. Anything to add on that?
Yeah, I would say, this is new to Evergreen and new to me as being new to the organization as well, but definitely we'll get into some lessons learned later, but I think, really looking at those high impact levers that kind of interact. So we have to think about, physician recruitment. Okay, we don't want to start planning for our recruitment for next year, like right now, we need to have a long-term plan and start sourcing those candidates well in advance so that we can have them teed up. Otherwise, we're not going to be able to meet our recruitment goals and not be able to meet our growth goals. And that's, we have learned as we've gone into this year, in all transparency, we started at the end of January, we were 22 provider FTEs below budget. And we have, we're budgeted to grow by 50 by the end of the year. So we're in the hole, bottom line. And so we realized very, very quickly that we need to pull kind of all hands on deck to say, okay, our provider recruitment team is kind of over here and working with individual service areas. We need a more consolidated viewpoint of what's going on so that we can increase the likelihood that we're not going to hit our FTE budget this year. It's too late. So knowing that, what are we going to do to plan for next year and the year after? So that's kind of the conversations that are underway. So I guess it's the reasonableness component of the planning process. What can you really achieve? And anything looks good on paper, right? But if you can't execute, it's not going to help us. So.
Yeah, absolutely. And please feel free to raise your hand if you have anything to add, or if any of these drivers, specifically speak to things you're doing at organizations. I think we've got someone with a microphone that can come over and.
Just tell me the components of the market assessment of your previous slide. I'm interested in knowing what goes into that marketing assessment, what the components are. If you could share that.
Sure. So you're talking about sort of that first, that before we get going with the year, sort of how are we assessing the market? Yeah. So we've at Evergreen we have a team of people that are our planning and market assessment team that are looking at everything from anticipated changes in population to how do we see different disease growths evolving in our area. And we'll get a little bit more on in a further slide into sort of the other elements of growth that are sort of in that assessment. But really it's, and in any given year, there could be a specific looking at competition, looking at new players in the market, looking at, not only do we want to focus on how do we strategically grow, but are there some defensive moves that need to happen in order to maintain, our targeted market share. So it's really sort of that comprehensive look at the market. Curious if you have anything that you would add to that.
No,
okay.
Not a thing. I was just curious what the components were.
Yeah.
Because I think consumerism in healthcare is where it's going.
Yeah.
Whether you all like it or not.
Yeah.
So I was just curious your approach, and I understand that approach.
Yeah.
And Hilton Hotels, those guys have been doing that for 40 years. Trying to figure out what consumers want and where and why. So
yeah,
that's all.
That is a perfect lead-in into this next element here on this slide, talking about patients taking an active role as consumers in the healthcare industry. So it's exactly what you're talking about, and it really kind of is forcing healthcare as an industry to be a little bit more creative and innovative of the ways to provide care, because people have choices and they're getting more and more access to information to inform those choices and act, as consumers maybe more so than ever in the past.
Yeah, I saw a little brief snippet on LinkedIn the other day, and it was a physician who had ruptured his Achilles tendon, and he went to Clinic A, Physician A and Physician B. Physician A was kind of a private practice, high volume, and the plan was surgery. And by the way, you need an MRI, but I can't help you schedule it. You're going to have to kind of figure that out. System B was a health system and a physician who said, let's evaluate your options and let's talk about is there a less invasive approach to try. And so he wound up going with physical therapy, wearing a boot, and having a plan, and he felt just a whole lot better about the experience. And I think that's just kind of a simple example of where I think we need to evolve, right? Because it impacts cost, it impacts patient satisfaction, And it's really just overall better outcomes at the end of the day. For me personally, I tore a meniscus in my knee and met with the surgeon, and we evaluated options, same thing. Let's try physical therapy and some anti-inflammatories, and I was really lucky it worked. Knee is great, no surgery. But she could have said, oh, I think you need surgery, and let's just go straight there. So it's really doing the right thing is another big piece of it.
Yeah, great example. So next is sort of the a rise of complicated chronic diseases. So this increases the need for comprehensive care across a patient's lifespan. So, just another example of sort of looking at that continuum of care and really thriving to provide, all of the services, all of the options, all of the choices as chronic diseases increase in our population. Another example of sort of that comprehensive care is when we think about bariatrics is a program that Evergreen Health has been sort of growing recently. And we think about, the non-surgical management, preventative care of obesity and, how you can, make choices in certain stages of the process versus maybe it will rise to the level of needing the surgical services, and then of course, the post-care monitoring. So looking at this whole service line versus just sort of treating one element at one point in time.
Yeah, I think I learned recently a lot about our bariatric program because we're looking at, we're doing an expansion of some of our space. And it was interesting to hear how our program is different, and I'm sure you all have many examples of programs similarly situated. But really the goal is on, can we manage it through diet and counseling? What are we trying? But if we need to go the surgical route, we're not done with the patient after surgery. There's ongoing follow-up into the future to ensure that the surgery is a success and that the weight loss is maintained, and their metrics are phenomenal. Very, very, very impressive. So that versus, I'm going to go see a bariatric surgeon, get banded, get whatever, and be done. So,
Yeah. And then another driver is just changes in different payment models. And looking at care coordination. We look at when we're thinking of being able to take advantage of bundled payments, making sure that we have the suite of services that would allow us to take advantage of those types of models, and also just in general sort of unnecessary duplication of costs in the system, trying to just look at that bigger picture. And then, of course, margin pressures. So we are talking about financial planning after all. And how does this, this is a huge driver of trying to say, okay, we have these long-term financial goals, and how are we going to align these specific service line initiatives to meet those goals and working backwards from it. So it really all does, result in that greater focus in managing operational and quality-based metrics. We're trying to reduce the cost of care and really meet the margin goals in order to, generate cash to fund capital. So we will talk a little bit more about that in the next slides. Are there any other questions or comments, things to add to these drivers?
maybe an example of. Don't forget the candy.
Thank you. Talking about the planning and stuff, and earlier talking about generations and they're accessing healthcare differently than some do. So, is that planning coming for that generation? Because they're maybe not coming to the physical location; they rather do it, telemedicine type. And so, does that plan for the future how they're going to access care? And now with value-based, with the different payment schedules, how does that all come to play, especially with Amazon and Walmart now coming into that environment, who understands that, that population and that generation?
Yeah, especially they're in our backyard, so that's our patient population. So I'll maybe start and then you can chime in. So we have a virtual health strategy, and we have an individual that's focused on that and really looking at opportunities in various different ways to create those different access options and to build. We were kind of talking about that last session, this idea of, those visits or the non-patient contact, not even telephone contact visits, is there revenue opportunity there to meet, but we want to meet the service needs of the patient. So that's becoming part of our planning process. As we all know, that's risen in need since the pandemic. So I think we're all kind of wrestling with that same thing. And I don't know if anybody has examples to share of that strategy. Anything to add, Jessica?
I think one of the, if we're thinking of silver linings of the pandemic, I think in general, healthcare can be more of an industry that's slower to make change. But I think one of the things that came out of it was just this immediate need to, particularly, and other organizations were already more, further down their journey with telehealth, but particularly for Evergreen Health and our organization, it really sort of just gave the boost that was needed to say, now we don't have a choice. Let's move forward with our telehealth. Let's figure out how we're going to provide the care and how we're going to get paid working with insurance companies. And so it really, it's one of those things where it just kind of gave that last boost to really make that program more robust. And hopefully then we can just use that momentum and go forward. And, it was going to happen no matter what. And so it's really sort of, I feel like it's one of the sort of silver linings that just helped, push that initiative forward maybe faster than it would have, because we just didn't have a choice. But of course, thinking about, younger populations and convenience, everything is just right there on your phone, there's got to be an app for that. So, this is really no different anymore. And, having it be convenient and accessible and, certainly planning for change in patient behavior in the next 10, 20, 30 years. Yeah, great point.
Yeah, and the pessimist side of me says, what about the medical legal risk? There's got to be that balance between what's appropriate to be done virtually and when does the patient need to be seen and examined, by a physician sort of face to face. So I don't know that we've necessarily hit that sweet spot kind of across the board, but we have definitely seen a change in the pattern of access of virtual visits across specialty lines. So endocrinology, pretty easy peasy. It seems to work really, really well. Cardiology, maybe not so much. So it'll be interesting to see sort of how that evolves. So, good question.
Yeah. Great. So now that we sort of talked about all the things that are driving the need for this service line approach, we're going to step through the highlights of our process of how did we go about this. So it was really a collaborative effort between the whole organization and finance and operations coming together and working on developing key volume metrics for each service line. And then also, of course, the anticipated volume growth in conjunction with operations. So I alluded to this slide a little bit earlier when we're talking about the different elements of growth. And so this goes into your planning, when you're planning for growth, kind of considering these 5 key things. So now I'm looking at the graphic on the right-hand side of the slide. So population growth, as we mentioned, and it's not only the size of the population, but sort of the demographics and the age of your population and seeing kind of what services might have more demand. The prevalence and different treatment types of certain diseases. Market share. So just because we're growing, doesn't mean you're necessarily gaining a bigger piece of the pie. So making sure that this growth is very intentional so that you're actually gaining more market share in the areas where you desire to do that. Physician recruitment is really sort of the crux of everything, right? So we need to have the right complement of physicians at the right time in the program in order to grow it in a way to meet our long-term goals. And then, of course, focusing on reduced leakage. And thinking about this continuum of care and providing sort of the soup to nuts services for a full service line is part of the strategy there to make sure that we're having patients stay in the system versus going elsewhere. So that's how we approached sort of developing growth, and breaking it down into those elements kind of helped figure out, if we want to grow, 10%, where is that 10% coming from? Is it just population growth? Because if it's just population growth, which other of these 4 elements can we be building in to maybe grow even more? So after we came up with our growth assumptions, we want to make sure, of course, that we're aligning the physician assumptions with the hospital facility and support services, including capacity. So one of and this was kind of a lesson learned along the way, I would say, for us, is if we're anticipating to grow a certain service line, tremendously over the next 5 years, are we sure that we have enough people to do the billing? Are we sure that we have enough bed capacity in that area? Are we sure that we have enough support services? Because if we don't do that, then we've got a blind spot where our plan won't work. So making sure that all of the various areas in the organization are involved in the process. It's truly a collaborative effort. Certainly not, and you all know this, but certainly not just a finance-focused exercise.
And if I could add, and there's a question. So let me just add one thing real quick before I lose my train of thought. So a really great example for us, as we plan all this physician growth, it's where are they going to do their clinics? We are landlocked, we are out of space, and the lead time, as I've learned here in Seattle, is really a long time to get, kind of fresh new buildings. So really then looking at, okay, are we maximizing the utilization of our exam room space? Are we looking at days of the week instead of 8 a.m. to 5 p.m., Monday through Thursday, half day Friday? Should it be 7 a.m. to 7 p.m., Monday through Friday, and half day Saturday, to expand the capacity that way? We have a huge opportunity to get more disciplined in that area, to create more capacity short term. That piece will work. Getting extra beds, that's another little bit of a challenge. So,
you said that some of that was a lesson learned. Do you have a horror story you could illustrate it with, so that so we just get a feel? Because I'm sure everybody has these kinds of things without feeling embarrassed or anything. Is there something you could tell us about where you left a group out, or a key support structure out?
Let me think about that for a minute. So, I think this is a pretty simplistic example, but it's the one that I think gets missed probably the most frequently. Our professional coders, right? So if we're going to add high-end neurosurgery, add more of those, they're hard to find. And we didn't, when we did the pro forma, did we assume?
Right.
And no. And when do we hit that point where we need more billers? Some of those basic, support services. Looking at, licenses, software licenses. Did we, where are we? Just some of that basic shared services infrastructure. And it's not, I guess we have to just accept that it's a work in progress, and that we're learning every time. And as long as we learn from those things and don't make that same mistake again, we get better. So.
And then I was going to ask, have you guys looked at later hours on one day or the week or the other to help serve people that have trouble getting in during normal business hours?
Well, have we or have I? I'm the squeaky wheel that always asks the question. So we do have some extended hours, but almost exclusively in our primary care areas. So our specialists, we have a huge opportunity. I think, from everything that I know about my years in healthcare in different markets, patients want that extra, even with the specialist, expanded hours. So it's, and it kind of gets back to what we talked about in the last session, and that work-life balance and the new generation of physician, and I want to be 8 to 5, and boy, I was really shocked to hear somebody suggest that more than 40 hours a week should be, something we'd expect. It's just a really interesting, and here in this market, way more pronounced. I came from the Chicago market, super competitive. There were more physicians. There's 5 academics, lots of feeders for physicians, and the comp levels weren't at what they are here, and the expectations were very high for productivity. So it's just, adapting to what the tolerance, I guess, and finding the balance. So.
Thank you.
Other questions?
Going back to your first question, it was the sort of the billing and coding example that I was referring to, and so really it could be in any area though. So it's all about thinking about where's that threshold, or where's that tipping point where now all of a sudden we really need to be involving revenue cycle or a different area, or IT, or a different area of shared services. But that is the one where we sort of got caught, was the billing coding, and are we going to be sort of out over our skis by the time we've grown into our volume projections, and needing to backfill support.
Great. Should we want to go to the next slide?
Yeah. I'll just touch really quickly on the last 2 bullet points. So what we did was we started with a 5-year forecast. So we came up with sort of 5-year forecast by service line. And then the ongoing monitoring of performance and adjustments to forecast as needed. This little innocent bullet point is not so innocent because, as we all know, things are changing so rapidly and dramatically that it's almost as if, the moment the ink dries on your plan, it's already stale. So having to be really flexible and agile and sort of monitoring as you go along and kind of determining the appropriate cadence of refreshing the plan. Certainly not a one and done. So that's another thing I'm curious to hear about, sort of the cadence of how you all may do refreshing of whether it's a long-term forecast or even a sort of a rolling budget or forecast during a given year. So are there any thoughts on that?
Nope, I see one back there.
So at Western Region HFMA, there was a panel about budgeting and the challenge that CFOs of, I believe it was 3 to 4 health systems have with budgeting, and to your point, with adjustments. How often do you see yourself adjusting when it's appropriate? Is it only when certain things happen around us, like COVID, or now perhaps the utility spike or the price increase? Or is it more of a discipline? Every quarter we'll take a look whether we're really on target?
That's a really, really great question, and I welcome others to chime in as well. I can start, and feel free to chime in. I would say historically at Evergreen, we were used to sort of a static budget, where we develop the budget, and then for the next year, we're learning about how things changed and kind of explaining those differences. But at the same time, that budget was developed with an intention to hit certain targets, so that if we're off in a certain area, we know that we have to make it up in a different area. So it's not that it becomes totally irrelevant, but it gives you, you are, obviously things are changing. When COVID hit, we immediately recognized the need to do sort of a complete reforecast for the year, because things were changing. With the shutdown of elective surgeries, it wasn't even comparable anymore. So I would say, I think in 2020 we refreshed our forecast every couple of months. With the changing regulations and just there's these volumes that were just so very different than what we were expecting. And again, I would say that was another sort of boost that maybe we needed as an organization to look at more of a dynamic budget and forecast going forward. So we still don't have a formalized process for doing sort of like a quarterly refresh or something like that, but it is we are looking into certain tools that will help us do that going forward. And knowing that even this year so far, things did not start out the way that we thought it would. And so we're certainly, from a cash perspective, we're doing a lot of sort of reforecasting and planning. We're sort of focusing on the key volumes and big things, so that we can have a forecast that looks a little bit more like reality without going to every little department and level of detail, so that it's also manageable to do, because obviously it's a huge effort and a huge lift. And you saw on the calendar that I showed earlier that it's already a year-long process. Figuring out ways to sort of do that refresh efficiently and at the right cadence is something that I would say we're still sort of figuring out.
Yeah, I would agree.
I would just say that in my experience around the country consulting, you mentioned rolling forecasts, and that's kind of the term of the week, term of the month.
Yeah.
I find that the hospitals that are doing that, it's 100% based off board of directors' makeup and disposition toward it. You still have board of directors that will say, no way, I want that static budget. You know, I have a company, I manage it, and we're gonna manage to the budget. And others that, yeah, that makes good sense. It's common sense given the times and the volatility in our market. But I've not seen any of the hospitals that do have a rolling forecast that still do not have a static budget that they presented to the board. So they're not going without a net.
Yep.
They're definitely doing the rolling forecast, and in the way you just mentioned, not down to the nit and nat, but, you know, volume, cash, almost financial statement level type forecast. But a few have gone a little deeper than that I've seen, and they've done it in service line. Hey, we've seen this much growth in general surgery. It's coming back. So what do we do for the next quarter to two? But still, it's to me, almost every time it's, oh no, our board would never let us do that, or our board's fine with that.
Do you find that those organizations that do the rolling forecasting perform better financially at the end of the day? Does it make a difference?
I can't see a correlation yet, and I'm a statistician, so I haven't seen it. But I will. The other thing I'll tell you is that almost all of them have thrown out their 5 and 10 year forecast and say we're not even trying that any longer. That's just done.
Bummer.
That's a great perspective. Thank you.
Yeah, and I wanted to I mentioned, I don't know that we said it distinctly when we started this section, but our service lines that we focus on are our highest margin areas, right? So that's what funds the rest of the beast, if you will. So that's why our focus is there. That's where our growth is, and you know, our mission is to serve our community. And in order to be able to do that, we need to maximize the growth of those areas that make money. Bottom line. So.
Yep. So another opportunity, if anyone wants to sort of chime in with experiences about service lines, we're going to move on talking a little bit more about capital next. But any wins, what's worked well, lessons learned?
Does anybody have a great example of service line forecasting, analysis, any super exciting stuff to share on this side of the lunch hour? You get candy. Oh.
I love candy.
We have plenty.
I'll tell you a service line story that I ran into in a hospital in Houston, which is pretty interesting. It's in the other direction. The hospital was considering shutting down or eliminating or quitting their outpatient dialysis. DaVita's right down the street. You know, there's plenty of, back in the day it was mission critical, but now that there's plenty, every strip mall has an outpatient dialysis place. And they went to the dialysis people, and of course they were worried, job-wise. And, oh, but we produce so much goodwill. Our patients come into other service lines. So we did the analysis, and sure enough, they were right. They came into a lot of other service lines, but they were pretty much the day outliers for every other service line because they were all Medicare. So actually, they were dragging down the margins of all, the gallbladder or whatever else service line. So it was addition by subtraction. They got rid of the outpatient dialysis. Most of those patients did not come back to hospital XYZ for their gallbladder or for whatever. And the margins of the other service lines improved because they eliminated the dialysis, which was, I'm not saying we want to turn people away, but you asked the margin question, I'll give you the margin answer.
Mm-hmm. Great. That's a great example. Others interested in sharing? All right.
Okay. So now we're going to move on to talk a little bit about capital planning and capital allocation. This is a process that is definitely interrelated with all of our budgeting and forecasting and service lines. And so interested to hear, again, we have some sort of prompting questions here about organizations' capital planning cycle, and what is the term, do you do more short-term, long-term planning? And what types of capital? So, we've got routine capital, things that have a life cycle that need a replacement every 3, 5, 10 years, whatever the case may be. That's something that I'll talk a little bit about in the next slides. That we've kicked off just this year, a more formalized process for our long-term routine replacement capital, and then also strategic capital. So, linking it back to service line planning. Part of what was part of that, we've talked mostly about operations to this point, but a lot of what the service lines need to grow, a lot of times it will include capital. And so planning for those capital investments and sort of the timing of when you need that capital investment in order to support your future growth is really an integral part of the whole process. So this is a graphic. It comes from Kaufman Hall, one of the sources that we've used for guidance on capital planning, but also various other areas in our organization. It's a graphic that we use to demonstrate just the interrelationship between the different levers, cash, debt, operations, capital, and then how does philanthropy and other sources of funding come into play. So we've historically looked at operating margin and cash as the critical metrics for ongoing viability, and using the cash generated from operations to fund capital. But really, everything is interrelated. So it's you move one lever and you have to make up for it somewhere else. And I think that sort of the environment really can change which of these levers you focus on. So an example is that when COVID hit, our organization really sort of went into cash conservation mode. There are a lot of unknowns right now. We don't know what is going to happen, but we do know that we need to maintain this certain level of days cash on hand in order to be sustainable. And so it was almost like we're using these other levels to sort of solve for cash. And we took a really close look at our capital budget for 2020 and said, wow, is this still really the right time to make all of these investments? And we ended up doing, I mentioned that we did some reforecasting during 2020, and we took a really close look at our capital budget and created a revised capital budget so that we could conserve more cash, knowing that we weren't generating it from operations. Now, in a different year, and actually this is probably more where we're going in 2023, it's going to be a big focus on reinvesting in capital. And it's sort of a lot of our big pieces of equipment and different things are coming towards the end of life and need to be replaced. So making sure that it's depending on the situation and the environment and the time for your organization, maybe you're sort of solving for capital and using the other levers in order to achieve the investments you need for the year. So curious, does this graphic resonate with other folks, and how would you see using this in your organizations for capital or other financial planning?
There's a hand over here.
Yeah.
As part of your criteria for where you're allocating capital, what kind of return do you normally expect to see? And then how often do you review that investment through the lifetime of it to make sure you are getting that return that you were expecting as part of your criteria?
That's a really, really great question. And I think kind of leads right into our next slide here. So there are, I'm gonna start sort of halfway down the slide talking about the capital pools. So we have sort of organized our portfolio investments into different pools based on dollar thresholds. And those different dollar thresholds have different criteria and different expectations for return, and then also subsequent review. So we have our, over a certain dollar threshold where it requires board approval. These are the items that are going through a much more rigorous review process. So they're going through a very robust, quantitative as well as qualitative review. So you asked about the return side of things. We use a net present value assessment to assess all projects that are over this specific dollar threshold. And that's just one element that goes into the decision making. We use a hurdle rate of 10%, which I think is pretty standard, and anything that is approved and is subject to that board approval, we do an annual look back on the capital to look at what did the pro forma indicate we were going to do and how are we doing. So that look back could trigger an action plan. We aren't getting the return that we thought we did, so what are we going to do differently? Or it's just a good review to sort of affirm the process of our pro formas and the assumptions that went into it. So does that answer your question?
Yeah.
Yeah.
Maybe I could just add.
Sure.
So I get the great honor of working on the capital requests for ambulatory, which have totally a negative NPV, negative return, because they're feeding the beast, right? I mean, we're adding clinic space, and we have physicians there, and we know that physician enterprise loses money. So, the quantitative piece is only one component of it. But we are expected to still do the look back and see, did we achieve the performance that we forecast when we did the NPV? So.
Yeah, it's a great point. Yeah, another comment here.
As you look at expanding those underperforming physician practices, do you have plans to make them perform better, or do you expect to keep them operating at a loss? Do you think about automation or other, fixing the mix of maybe lower, whether it's different kinds of nursing staff to get the right kind of professional service mix and lower pay resources? What's the plan long term? And I don't know that you guys are planning the profitability of those physician practices. It might be someplace else, but what kinds of ideas are tossed around?
Yeah, no, my job is 100% is improving the financial performance of the physician enterprise. And so when we look at a few things, physician production and compensation, those are the two main drivers of financial performance. And you can only be able to do so much with it, but that's the first places to look. So we kind of set targets, in our forecasts. If it's a new doc, we have a kind of a standard ramp-up cycle and productivity, and we have a target comp range, and that's what goes into that piece of it. From a staffing perspective, we look at staffing ratios and we try to really leverage MAs and working to the maximum of their license.
Right.
But at the end of the day, of course, we're looking at investment per provider FTE, and is this new site better than kind of the aggregate of everything we've got going on right now? So that's kind of one litmus test that we look at.
Do you guys bring in any kind of standards to the practice leadership? How many nurse practitioners per senior doctor or anything like that? Is there any kind of professional services management stuff that you bring to them, acumen that you bring to them?
So that's on my dream list. I think that we have a huge opportunity to assess the way we utilize our mid-levels, and to ensure that there isn't opportunity to do it better, because we don't scrutinize the mid-levels the same way that we do the docs. For the most part, we have some mid-levels that are on productivity, and that's better optics. But no, I mean, it's a great point, and it's kind of just part of the evolution. So start where sort of the low-hanging fruit, right, which is where the bigger dollars are. So we started with the physicians, and we spent my first 18 months here really focusing on that component and seeing improvement in the overall productivity of the physicians, pretty significant improvement, which really helped our financial performance. We outperformed our EBITDA last year significantly. And I hate to brag, but my division is the only division that's on budget so far this year. So, now embedded in there is some, kind of ups and downs, but at the end of the day, yeah.
There's a really old book called Managing the Professional Services Firm, and it just talks about that mix of senior resources, mid-level resources. I know it sounds basic, but physicians focus on medical stuff so much they don't always think about the mix of managing a professional services firm.
Yeah, and AMGA actually has some really good resources in that regard. So I threw that out there as an idea of an initiative, and that, along with space utilization, did not get warmly embraced this year, but I'll keep trying. Okay, so time check. How are we doing? So we got about 15 minutes, 20 minutes left?
Mm-hmm. Yep. So I guess just a couple of more comments on capital. This is a process that we sort of started making more robust and having more structure around it a couple of years before COVID, which actually came in really handy, because having the structure and sort of moving from maybe whoever screams the loudest, or first come, first serve, capital allocation methodology, to more of a structure looking at, the qualitative analysis really has to do with, does it align with our strategic objectives? And is it in line with our long-term strategic goals? And we have a committee here, I referenced the capital committee, that actually hears a presentation on each of the proposed projects and ranks them based on criteria, based on, is it in line with our safety, quality, and regulatory goals, our growth goals, our, optimizing the core of our business. And so we use that ranking as one input, and then of course the quantitative, or the NPV analysis that we do, is another input. But another really key input, after we put those two together and see sort of where we have our, how do we want our portfolio of capital investments to look, is looking at, the urgency of this investment, because that may not come through in either of the qualitative or quantitative assessments. What is the urgency? And also, is it a feasible investment? It could make all the sense in the world, but if there's not feasible to do in the next year, so for example, if we want to open a new clinic, but we don't have a space to do it, it's not feasible. And so these are the types of conversations that the capital committee has in sort of whittling down our whole proposed list of projects to what we really want our portfolio to be, knowing that not all of them generate a return, and in a lot of years, maybe very few of them will generate a return, but looking at it as a whole portfolio to make sure that we're still achieving our long-term goals.
Yeah, I would comment to organizational capacity. So this was my first year in the process at Evergreen, and we get to the end and we have this list, and it looks great. Ambulatory is getting funded, and woohoo, we're going to be good. And then we kind of paused and said, okay, wait a minute. 3 of these projects are primary care projects. What kind of capacity do we even have to take that on? Operationally, is that even feasible? Well, probably not. Okay, so which of these can we drop from the list for this year and reassess for next year? Another one, we wanted to open another urgent care clinic in a targeted location. Well, there's no space. There's no space yet. There's no space in the foreseeable future. So what we don't want to do is encumber capital when we're not able to spend it. So it was a lot of those kind of really cool conversations where we came to a place where we have just I think a really great list that is well vetted, makes great sense from a strategy perspective, and will really be high impact. So. Anybody have examples within their organizations of similar things they want to share? Somebody online want to share? Anybody doing the routine replacement capital planning, kind of like long term, like a 10-year or 5-year? Anybody examples to share? Gotten really quiet. We're getting a little boring up here. Okay.
So that's something that we just, like I mentioned earlier, we started, we're in the middle right now of sort of our kickoff project of doing this longer term routine replacement capital. So it's very specific to this population of capital that, doesn't get a whole lot of, fanfare because it's not revenue generating. It's like kind of keeping the wheels on the bus type of stuff. But we got caught really sort of in 2022 where we had a lot of large pieces of equipment that were needing to be replaced. And so it takes up, if it takes up half of your capital budget, it's nice to know that in advance so that you can plan accordingly in the years before and after that year where you might have a bigger investment in these more routine items. So what we have done is laid out a 10-year plan, knowing that a lot of these pieces of equipment have a known life cycle, and just kind of slated it in to say, okay, and these are the years where we're going to have to be doing more just sort of routine replacement stuff, and we'll have less left over for strategic. And then we have other years where we have more room in the budget to invest in strategic initiatives, and just having that that visibility into the future. It's not a terribly complicated exercise, but it does take time, just like anything. And I think it will really help us with our long-term planning, sort of having that capital element built in. So So far, so good, having a little bit more structure there.
I wanted to add one other thing that I think is a very unique process, at least from what I've seen. So we established this like below threshold pool of dollars for each division. So it's intended to cover capital items below $100,000. So you get a pool of dollars based on what's left over from the rest of our capital planning, and then it's up to each division to decide how to prioritize and how to spend those dollars. And that has been really just a very wonderful interactive process with operations. So does anybody else do something similar like that, where you're kind of decentralizing a component of your capital? I see a hand up over here.
I have seen, and it will tie back to your service line discussion, where if you set an operating margin target for a service line, cardiology, and that the hospital has, or the healthcare organization has set if you come in 10% higher than the target, we'll set aside dollars that you and the service line can spend on capital any way you want, within reason. But I mean, I'm not going to go buy a popcorn machine, but I mean, they can spend it on something that they want, a gamma knife or whatever they happen to need. If they achieve a margin beyond what the organization expected. So it's kind of but it's service line for each one of those.
And increasing the pot, we, like every other organization, I'm sure, we have requests that are 3 to 4 times what our funding sources are.
Yeah.
So every year, yeah. Okay, are there anything else related to capital? Oh, Nick.
Hi. From a long-term trend perspective, I've seen a lot of increase in the IT capital budget over time. But with a lot of the cloud services, and actually that's one place where I've seen kind of, they just get kind of their independent bucket to spend what they want versus the overall spend. But I'm curious if you're starting to see, with the availability of a lot more cloud services, is the growth in the IT budget, IT capital budget still continuing in your case, or has that shifted, I guess? And obviously it's going to be unique to each organization, but I'm always curious where that's going.
So I would say that because of our EPIC project, but once we've got EPIC live, I definitely am seeing examples like workforce management solution for our call center. That was initially budgeted to be a capital expense. It's going to be operational. Yeah. Yep.
Yeah, and I think that's where, sort of going back to that slide with the bubbles and the levers, it's important that you're looking at the whole picture, whether it's going to be operating or budgeting, keeping your eye on cash. So it's kind of goes back to sort of that integrated process and financial planning.
Others? Okay, so we're getting short on time here. So just curious if anyone has stories to share about your budget process when it begins and ends. We kind of shared that it seems as though we're in perpetual budget season, or if there's examples that you want to share of an integrated process. And when I say integrated, I'm talking about that sort of that physician or professional component in alignment with the hospital or facility component. Any examples to share? Stories for Candy? You must be really hungry. It's almost lunchtime. Okay, well, if you think of anything as we go along, this is a short section. So this sort of just shows where our operations and capital funding, July through September, our board approval is done mid-November. So, and I mentioned we're a public hospital district, so those things are mandated in terms of, I believe the timing is mandated, and certainly the board approval is mandated as well. So that really tends to drive our timeline in this year. We're going to start even sooner because we're going live with EPIC on October 1st. So hang on, it's going to be quite the ride. Okay. So just kind of a high-level concepts that I wanted to share. We started, at least on the ambulatory side, and I think on the hospital side as well, really thinking about what are some high-impact items that are anticipated to either to occur or to go away during the upcoming budget year that would change the run rate, right? Because if nothing's going to change, we can just kind of roll forward with the same run rate. So, some things that we looked at: the ongoing staffing shortages, premium pay, agency usage. I can tell you right now, 2 months in, we missed the mark so far on that budget. We're way too optimistic. Implementation of new technology, that's huge on many levels, and especially when we're doing something as significant as EPIC. Elimination of COVID prevention and support services. Do we anticipate that at any time during the year? We've invested a lot in our drive-through testing. We've helped with staffing vaccine clinics. We've worked with organizations in our community like Microsoft in providing vaccine clinics. We still have the financial recovery as a result of the pandemic. Is there going to be another wave, right? Just trying to predict all of that stuff. And then, of course, your payer rates and what do we expect to happen there. And then using the 5-year forecast data, the divisional EBITDA targets were established to be in alignment. So that was kind of where we started. So each division had a number. This is the number you're going after. And then, of course, the fun began. We began again with the service line growth plans in the budget. So we had the hospital component and we had the physician element, but they were aligned based on our 5-year forecast. And then we had some of our, not all of our services fall into service lines. So we had non-service line facility volume, and that was based upon a combination of the run rate as well as kind of what we anticipated to be realized as part of the 5-year forecast. So for example, general surgery is not a service line for us, but we know that if we grow in these other certain areas, more general surgery cases will be generated. So we need to kind of factor that in. On the physician side, probably, it's what I've seen, and I don't know if anybody does it differently, but all the places I've been, it's really a bottom-up. So we start at the individual physician level, budgeting the RVUs and the visits and the compensation cases, et cetera, to roll it up to the sum total. And we did a lot of pre-populating of our budget assumptions, at least the key stuff, to get a good starting place for operations, and then let the operations team have about 4 weeks to have at it and fine-tune their department budgets. And it was quite interesting. It was my first budget cycle at Evergreen, and we used Strata for our budgeting tool, so I could run an income statement every day. And it started out so good. We were like, millions and millions of dollars favorable, and then every day a little bit more deteriorated. So it was quite the interesting process. But where we landed at the end of the day, we were successful, I would say, in our budgeting process. We as a system did not hit our EBITDA target in our budget, and we just realized that it wasn't feasible. We could make up numbers and make it work, but we wouldn't achieve it. So we accepted that we had to pivot and sort of have not quite as positive performance. But I think that the operations teams buy into it and realize that it's probably more achievable. I want to do a deeper dive really quick into the medical group process, just to share some things that I found helpful and maybe helpful to you as you are in the midst of the budgeting process. So I asked Jessica's team to create some reports for me to kind of have an ongoing sense of the reasonableness of the budgets that were going in. So there were reports that were done at a department level as well as a specialty grouping roll-up, so I could kind of see for executive directors what was the trend in their area. So we went all the way back to 2019 through projected 2021 as a history, and then we compared it to the actual budgets as they were evolving. And we looked at everything from work RVUs, provider FTEs, that ratio of RVUs to provider FTE. We looked at EBITDA at a department level. Again, if you're looking at it over these time periods, it really tells the story. Women's health, for example, had a positive bottom line in 2021, and they were budgeting a huge swing the other way. So how come? Let's drill into it. We looked at the net operating income, or really loss for the most part, at a department level, as well as per provider FTE within those departments, so that we could get some ratios in, and just a few other things. But really, that helped to identify things that are changing unexpectedly, and the reports focused on really those high impact areas that are physician productivity, physician comp, and staffing levels. So, anybody have any of their favorite reports that they use for budgeting? Has this rolling together? Anything to share? Okay. All right. So I wanted to share. This is just really my favorite. My favorite report is this simple expense per dollar of operating revenue. It's like such an easy way to say to operations, okay, so every dollar of revenue we bring in, we spend, we're projected to spend $1.11, and now we're budgeted to spend $1.18. It just, that seems to be a very simple explanation. And so these are not our real numbers, but conceptually, you know, when you see big swings, and you know, it may not look very obvious until you kind of normalize the data. But then it allows you to drill in, and we actually found one big thing that had been budgeted and felt like it got kind of snuck in there. And so we were able to have some good conversations about whether or not that was the right thing to do. So just a report that is one of my favorites. So integrated budgeting process observations. So, and I'm sure many of you have encountered this, but the budget spread for a physician practice is so different than a hospital budget spread, right? So I started in October of 2020, so I wasn't part of that 2021 budgeting process, and we had a very difficult start to the year in 2021. I mean, we were way off budget January and February. And as we drilled into it, it really was a lot to do with the budget spread. It was the FICA, the retirement matching, but also our contractual adjustments are not. It was they were not budgeted based on historical run rates. So, questioner.
Well, this is Marnie. I'm a little late to the party, but I was going to offer a suggestion on some of my favorite reports that I use. So one of the things that is certainly we're always caring about is labor costs. So we use a lot at looking at labor per key stat. And I have a roll-up of all my departments and can tell, you know, we're very focused on benchmarking, and so making sure that as people are building their budgets, they're not sneaking a little bit in there, or to make sure that we've had those conversations. The other thing we do with our departments is my expectation is that every leader is covering the cost of their supply inflation every year through various initiatives. So I have a report that looks at the percentage increase per unit of service on supplies expense. Now, not all departments are able to do that. Places like pharmacy, you know, which double-digit increases, you know, may not always be able to cover that inflation cost. But those are some of the ones I like to look at, and I think can be applicable for both hospital and medical groups.
That's a really good one. You mentioned sort of trying to put controls in place to make sure that people aren't sort of sneaking in FTEs here and there into their budget. One of the things that we do is we call it the Workforce Optimization Council. And so it's actually a committee, and we now have it at a division level where new ads actually sort of have to come and present to this committee to get an approval to add a new FTE. And we try to do that before the budget so that all of the inputs into the budget are sort of pre-approved, so to speak. So that process, I think, has really helped us just sort of control that, you know, that huge swing where you start out with your budget and you have a huge increase in FTEs, and you spend the next month or two just sort of whittling it back down, just trying to start out at a more rational place to begin with, is something that I think has helped us and that will continue, given that staffing is such a large portion of our operating expenses.
Great. So I guess maybe the last thing that I'll mention on this slide, and then we'll open it for questions, is we really, the integrated portion of this process, we really looked for consistency between hospital and medical group assumptions. So, was the physician review growth consistent with hospital growth? For example, our deliveries, surgeries, was there alignment there? And we were able to push back in areas where there wasn't alignment and actually have some additional budgeted volume in certain areas. So I think there's still much opportunity and work to be done, but that was I would say that was a big success in our process. Yeah. Anything to add there? No. So I think we can skip the last. Yeah. So I guess what we like to open it up for any questions or other things that if anyone would like to share related to their processes. That bowl is still really full.
but thank you for all the participation. Yeah. I can really feel the energy in the room about financial planning.
Yeah. All right, any questions? All right, well, thank you all. Appreciate it.
Thank you.